Hello, welcome to Aging Well in America. I'm Anne Marie Gattari, your host. Every day, up to 10,000 people in the United States turn 65 years old. 5.5 million people are older than 85. By the year 2050, which isn't all that long from now, 20 million people will be aged 85 or older. Are we ready? Is America ready? There's so much good work going on around the world, around the country, and right here in our own community. And today we have with us one of those people who is doing some of that good work. Welcome, Sarah Thurston.
Hello.
Social worker from Great Lakes Caring Hospice.
Correct.
You bring today a topic that we are all so very interested in. It's like we can't get enough information about dementia.
Correct.
And you're an educator. You train other social workers and nurses on how to understand dementia. So start with what was interesting when we were speaking a little bit before. You said there's really 4 main types of dementia, and it's important to know which one we're dealing with. Can you tell us a little bit about each of those, please?
Yes. Well, first of all, when dementia is an umbrella, and it's a symptom of things. It includes memory loss, includes behaviors that have changed, mood instability.
Mm-hmm.
So we're talking about dementia, we're talking about symptoms that you see.
Mm-hmm.
So when we're talking about deciding what type of dementia it is, we want to make sure that we get the right type, because there are some instances where the symptoms can mask a urinary tract infection.
Right.
Could look like dementia in the elderly. So you want to make sure that what you're seeing is actually what we call, the chronic, the diagnosis of dementia, where we are looking at a long-term disease process. And some of those major ones, we have Alzheimer's, which is very common. People understand what Alzheimer's is for the most part. But we also have Lewy body and Parkinson's dementia, which are kind of correlated. And we also have vascular dementia.
Okay.
And we also have frontal temporal dementia, which is also referred to as Pick's disease.
Pick's disease, okay. So a couple of points about each of those and what's different in terms of the symptoms or how it presents.
Correct. And the reason that we like to diagnose which type is because there's different treatment options for each one. The behaviors look a little bit different, especially in the beginning. And what we look at is the beginning stages. What is affecting? What is presenting? What the people are most familiar with is Alzheimer's. We think of memory loss. And that's because memory is usually typically presents first. So when we talk about somebody with Alzheimer's, you're talking about somebody who forgets where they work. They forget where they left their keys. And we're not talking about, just sometimes we all forget where we left our keys in the morning. We're talking about something that impedes our day-to-day living. The families start noticing that they're a little lost. And that's where memory starts first.
Right.
And then you see gradual changes as the course progresses with other types, with other symptoms.
Some of the things that might be even make it, we may say, why do we need to know? What difference does it make? But with Alzheimer's, for instance, not only forgetting something that may be seemingly common, like where are my keys, but forget to eat, right?
Correct.
Or forget that they ate and
Correct.
eat again. That
Right.
was what my mom's situation
Yes,
was.
you see that often because they don't remember, and there's a disconnect between all the body systems, so they're not even hungry, or so they might have eaten a couple times, but their body's not telling them that they're full.
Right.
So you do have that memory loss affects everything. So yes, it affects so much of their day-to-day living, and that's why we can't, there needs to be 24-hour care usually. It does really affect how we, how we go about managing this disease process. And then some of the other ones, vascular dementia, very hard to diagnose because it can affect any part of the brain. It is usually related to hypertension, cardiac problems, so you have problems. Congestive heart failure. So these are things that can affect whether you develop vascular dementia. And because it attacks different parts of the brain, it can affect different symptoms can present a little bit different. So that it is a little bit more of a challenge. You could also have some doctor could diagnose Alzheimer's and vascular at the same time because there's two different causes. So you could be looking at two different things.
Okay.
Vascular is often stepped down, so whereas you see Alzheimer's is a gradual decline. You can just see the person changing over a course of time. With vascular, you see a big change and then a plateau, and then a big change and then another plateau.
Interesting.
Often, that can be a sign of vascular dementia.
Right. And then the other two you mentioned, one affects the frontal.
Frontal temporal. Frontal temporal lobe is very different. It's a little bit of the minority of the major types, so it is less common. It typically will start in the younger population. So whereas Alzheimer's increases, the chance of getting Alzheimer's increases with age. With frontal temporal, the younger you are is when it attacks usually. So it can start in the 60s and 70s, whereas Alzheimer's might be closer to the 80s.
Okay.
And it also can start as early as the 20s. We have had some diagnoses that have that young in frontal temporal. Frontal temporal affects the frontal lobe and the temporal lobes of the brain first. And that's what affects our stop button. It's our executive function, our decision making. So unlike Alzheimer's, where you see the memory loss first, frontal temporal, you'll see more odd behaviors. You'll see somebody make poor decisions. Maybe they were very, very polite all of their life, and all of a sudden they're making very rude comments to people when they meet them, saying things that are on their mind. Because the executive function tells us to stop doing, it's our filter. It tells us to make decisions and the appropriate decisions based on social norms. And when frontal temporal lobes of the brain are affected, that is when all of those decisions don't get filtered.
Right.
They don't get filtered.
So one of the questions I asked you early on is, what does it matter? I mean, if you're an adult child and you have an elderly parent who is showing some of these symptoms, what does it matter? Is treatment realistic? Will it make a difference?
It depends on what type. I think as we've gone through and more people have experienced a loved one with Alzheimer's or with some sort of dementia, we get more familiar with the things out there. One of the common medications is Aricept and Namenda. Those are to treat dementias.
To slow down,
and that's the difference. People have I think there is a little bit of misunderstanding out there that they're going to make them a little bit better, but it really just slows the process down. And it only works for so long. So even if it's slowing it down for a period of time, eventually the disease will catch up. It won't be able to be slowed down anymore. And what is not common knowledge is that Aricept and Namenda and the common medications out there really have only been treated for Alzheimer's type. So if you do have a loved one that is diagnosed with frontal temporal or Lewy body, those medications might not be your best options. The other, we didn't talk about Lewy body yet, but Lewy body has one of the big signs and symptoms in the beginning stages is delusions and hallucinations. So there's a lot of what we call psychotic type behavior.
So someone who's showing those symptoms may be diagnosed or misdiagnosed as having a mental illness.
They could. They also, Lewy body is associated with Parkinson's disease. So also with Lewy body, sometimes you get the Parkinsonian symptoms. So those are correlated. Those that have been diagnosed with Parkinson's, who later show cognitive decline, may also have Lewy body dementia. They all both attack the same parts of the brain. And that's what starts first, delusions, hallucinations. And the difference between a delusion and a hallucination, a delusion is a belief system, a fixed belief, something that is not correct. You stole my purse this morning, could be a delusion. Whereas a hallucination is where I see that boy over there that is not really over there. But both of those can occur with somebody with Lewy body, and those are what you see first, especially the delusions and paranoia, thinking that people are doing things wrong to you. And that is the interesting thing about wanting to know what diagnosis it is. those can be very harmful, those delusions. They can take a toll on the quality of life.
Yeah.
And very distressing both to the caregiver and to the person, and you want to make those delusions stop. And with Lewy body, if you use certain medications that help delusions and hallucinations, they could actually make them worse. So you really want to know what diagnosis it is, because if it is Lewy body, you want to use the correct medication to help those delusions and hallucinations, so that they aren't as stressful on the person. Because a lot of times they are negative.
Right. Yes.
Sometimes we all have experienced the person that's been diagnosed with Alzheimer's or Lewy body that does have a hallucination or delusion, and it's not distressful. It can be pleasant. But we want to look at, is it pleasant, or is it causing distress? What are our treatment options?
Yeah, yeah. Excuse me. Everything you're saying right now is just bringing back a flood of memory for me, because my mom showed signs of all of that. She was 89 when she passed, going on 2 years ago, and her last year was really a rapid decline and kind of a mix of a lot of these things. And my sisters and I got to the place where we kind of figured out on our own. We didn't have the guidance of someone like you to stop trying to correct her and put her in the here and now, because it did just make her more distressed.
Right.
So when she would wake up in the morning and say, there's a little girl who's crying and her nose is running and her face is dirty and she's standing in the corner, I got the idea of asking her, what did the little girl look like? And she described her, and then at one point we even got out a family photo album, and she pointed to my sister, who was, when she was 7 or 8 years old, and said, that's her.
Oh, how amazing.
And it was amazing. It was touching. But what we tried to do was, just change the atmosphere, change the situation, and let her know that, the girl was not in distress and she was coming to say hello and try.
That's correct. And it's very uncomfortable, because as the disease progresses, our options are limited. The medications don't always work. And as you're correct, as the disease progresses, it doesn't matter which type, you might experience a broad range of symptoms, so that you see hallucinations at some point, whether they have Lewy body or they have Alzheimer's, because all parts of the brain are affected. And it is important, what are our strategies at that point? What do we do? And because it's the brain, and it's the brain that's deteriorating, it's an amazing thing to try to figure out what our options are. And I think you guys hit it on the head. Is it's called validation therapy. And that's what you were using, whether you knew it or not.
Yeah, it didn't.
And validation therapy is acknowledging that what they're really experiencing, that their emotions are really experiencing the little girl that's crying. They're really experiencing that somebody stole their purse. And it's not our job to correct them and argue with them, because the brain isn't allowed to process what our reality is, which is the truth. They can't comprehend that. Their brain isn't allowed to take in that new information and think logically through why that little girl isn't there, or think why I know I just misplaced my purse. They're not capable of that. So what can make the situation better? Validating the emotion. They're really experiencing that hurt. They're really experiencing that somebody stole their item. How would that make us feel?
Right.
And having somebody reach out and say, I understand that you're feeling that way, and I am sorry that you're feeling that way, can actually help the situation far more than trying to correct them and saying, no, your purse, you misplaced it, we took it because we didn't want somebody else to take it. Trying to explain that might make the situation actually worse. The other thing is that they're able, unlike they are unable to retain new memories, but they are able to retain emotions. And so when somebody does something to them, or they perceive that somebody has done to them that it's not good, that they've harmed them in some way, they're going to remember that. They might not remember the incident that made them think that, but they're they're going to look at you and go, I don't like you.
Yeah.
So when we talk about caregiving situations, and that's hard. This is your mom. This is your spouse.
Yeah,
this is,
you're a family
yeah,
member.
you're a family member, and all I've done is treat you well and be nice to you, and now you're mad at me, and I don't know why. I didn't do anything. So we have to be careful that we remove ourselves right away from the situation and don't try to continue to argue.
Right.
We want to distance that emotion from them of disliking us, so that they can retain a new memory of that they like us, they trust us.
So would you, that was another thing my mom did. She really had it in for my oldest sister. She did accuse her of taking money, and we each had our day, you know, and the day that my sister Rita would go spend with my mom, she was always mad at her. But how do you take a situation and turn it around? Rita did what she would do, which was try to make light of it and make humor of it. But then my mom sometimes felt like my sister was making fun of her.
Right, because there's a misinterpretation of the body language, of the tone. Really the best thing is to remove yourself, as hard as it is.
Literally walk out of the room?
Yep, walk right out of the room. Sometimes they can, because their vision is also affected, their perception is also affected.
Okay.
Changing your outfit, changing your hair, those can all help. Not that every case is going to be the fixer, but it is an option to try.
But maybe just walk out of the room and come back a few minutes later and with a different discussion, starting a different discussion.
Correct. And also bringing something that they like.
Yeah.
You know, not asking them any questions, it's hard for us to remove ourselves because it's our loved one and we want to make it better. We want to fix it and we want to tell them, I didn't do that to you. And so it's a hard thing to do, to walk away and let somebody else try to resolve the situation. If you bring somebody else in, we can distract them and remove the agitation, because the longer that we stay there, the more likely it's going to increase.
You gave one of the most powerful examples I've ever heard at a program that I heard you speak at a while ago about somebody who's an amputee, a lost arm. Tell that example.
Yeah,
again,
and I think what we struggle with the Alzheimer's and the Lewy bodies and the things that affect the brain is that we can't see it. We can't see the problem, and the fact that the brain is actually deteriorating, that the synapses aren't firing correctly and hitting their marks, so that we can do this. And when we have somebody who has, let's say, an amputee, let's say that they do not have an arm, we don't ask them to pick up a glass of water. We can see that they do not have a hand, so what do? We don't ask them to keep trying to pick up that glass.
Right.
If you keep trying, you'll get it. But what do we do with our people with dementia? If I say your name more, if I ask you, if I quiz you, if I keep reminding you, you're going to get it. So if I keep telling you that my name is Sarah and I'm your daughter, you're going to remember. What we don't see is that the brain can't retain that information anymore, and it can't. It's almost like a missing limb or a missing appendage.
Right.
We can't.
So continuing to correct and remind is sort of like asking an amputee to pick something up?
Correct.
That's really powerful, and I think something that so many of us adult children, if we could just remember that and you know, kind of stop it's so very frustrating. I mean, there's so many emotions. It's a mourning. You're grieving the loss of your, you know, the self, the parent as they once were, and you're frustrated and you're angry at the way they're treating you, and
they're asking you the same question over and over and over again, and if you answer the same over and over, it's absolutely exhausting.
And
it's exhausting.
I finally came to realize that you know, there was nothing in my growing up that prepared me to be this caregiver. And that's when, you know, my sisters and I decided, yes, we need some help, and we brought people in. I mean, we still continue to spend the time that we wanted with, and that we could with her, but we weren't the only ones. We had to have professionals. We had to have, an agency come with professional caregivers who really could sort of guide us and set an example.
Yes, and I think you need breaks. Because even the professional caregiver, and I can tell you, those that work in placements or that go to the homes 8 hours a day, they need that break because it's exhausting and trying. And when we try to be there for our loved ones 24 hours a day, 7 days a week, we don't get that break.
Right.
And we need that mental health break to step back and take care of our own. And we do need additional help. And part of the reason is because the length of these diseases.
Yeah.
We're not talking, 2 to 3 years most of the time. We're talking upwards to 10, 20, depending on when they're affected, what else they have going on in their health, how long they'll live with this particular disease. You need the professional help. It's vital.
When you see families in this situation as a social worker, and you see, an adult child, often a daughter, who is absolutely spent, but they don't think they can, or they should, or they just plain won't. I mean, I think some people, it almost becomes their life's mission, right?
Oh, definitely.
To stay involved and to be the main caregiver. How do you advise?
We talk about you're no longer able to really do the quality care that you think you're giving when you're that stressed. So you think you're holding it all together, but you're probably getting shorter and shorter with your loved one. You're not really taking care of yourself and your own needs, which means that you're not really being a good caregiver. So we talk about what they need to be able to be a better daughter, a better caregiver, and that's taking care of yourself as well. And it could be a lot of things. We have a lot of stigmas about getting help, whether it's full-time placement or bringing in caregivers to the home. Whatever decision that you make, we do get there's a lot of stigma attached to that,
right.
and it's kind of reducing that stigma and acknowledging that unless somebody's gone through this before, they probably don't realize the amount of stress that a family member goes under, and that it's not you're not being a bad daughter or a bad spouse if you seek out help, whatever you need to do for that time. That it's pretty much saving you and your loved one from emotional harm.
Right. And when you're involved, by the time Great Lakes Caring Hospice becomes involved, it typically is very close to end of life.
Right. Correct.
And I think, because it was our situation, but I think families are more inclined to receive the help at that point because they've made an emotional decision almost in their minds and have come to grips with where they are in life.
With dementias, it is because it is a long process. You do have those moments where you're able to say, well, I've lost this part of my loved one already, and I've lost this part of my loved one already. So it is a journey that you don't have to make the big decision all at once.
Right.
You've made these small decisions as the path goes. Not to say that's not hard when time comes. And there is some misunderstanding that, the dementias are not terminal, and these particular, the Lewy bodies, the Alzheimer's, they are. It's just that they are such a long disease process. Some people don't see those end stages, but they do reach an end stage. And I think there is also a lack of understanding is that it affects not only their mental capacities, but also their physical being. And remember, the brain controls every part of ourselves, which includes walking, eating, swallowing.
Yeah.
Those are all affected by the dementias.
If someone has questions, they're able to go to your website and call your 800 number. If we could put those up again, that would be helpful. 800-311-5365 for Great Lakes Caring Hospice. You've got people who will answer questions, even if they're not ready to call in hospice. And GreatLakesCaring.com is your website. We've got a few minutes left, Sarah, and I'd like to find out just a bit about you and how you came to this career decision. Hospice, I mean, you're a young woman, you're early part of your career, I'm assuming. Hospice and end-of-life issues are they're quite heavy.
Yes, they are. Well, I think it started probably when I was very young. My father got taken by cancer when I was very, very young, before even memories. I was only 3 years old, and I think because of that, end of life always became just a very natural part of life for me. I had a mother that made it very normal and an experience that I was very comfortable with. And then I had the opportunity to be at my grandfather's death when I was 16 years old with hospice. And it was one of the most beautiful things I've ever seen and experienced.
The word opportunity.
Yeah, and unless you've had that time with somebody, it's hard to explain. But it is an actual beautiful moment. And I think from then on, I decided that was something I felt very passionate about. And when I got into grad school and social work, I decided I wanted to try out hospice as a profession, and I fell in love with it. The amount of care and compassion and the amount of time you can spend and improve that quality of life is tremendous. And being in sometimes the nursing homes, the assisted living settings, at end of life, you see more and more of the dementias. And that became also a passion of mine, is to understand it a little bit more and do some educating, because there is such a lack of understanding about dementia. So it's kind of twofold. Both one experience led to the other, and I've enjoyed both experiences.
Yeah. So your position then at Great Lakes Caring as an educator is to train other social workers and nurses, both at Great Lakes Caring and in the community.
Correct.
You do you put programs on for
because with hospice, I was out in the field taking care of patients directly and family members. Because with hospice, every patient is assigned a social worker, so that was part of my field experience, and then I moved into the educating.
Okay. And Great Lakes Caring is where? Which areas do you serve?
Well, we actually serve most of Michigan. We're as far west as Grand Rapids and Kalamazoo, and as far, and we have the middle state, Lansing, and the east side as well. We also have offices in Indiana and Ohio. And we have both certified home care, palliative care, and hospice care.
Very good. Well, thank you so much for coming on the show.
Thank you for having me.
You're very welcome. We've come to the conclusion of another episode of Aging Well in America. This is a very, very important topic, and one we continue to learn about. Please do send us your ideas here at the War Memorial for future shows. We will be happy to entertain them. Thank you, and we'll see you next time.